All right. It's a great pleasure to welcome you all on next webinar on our Accelerate Mental Health program. So the program is being developed jointly with EHIS Tartu Biotechnology Park and Scanbelt Network. And the aim of this webinar series is to discuss about what are the main aspects and how these kind of support organizations and also doctors and other stakeholders could help to move along the innovation in mental health, which is a very important and relevant topic for all of us. And the overall aim of this program is to look if and how an acceleration or incubation program could be developed based on this. So we're hoping to continue with this topic also next year, if there's plenty of interest from stakeholders. And for that altogether, we have continued collaboration with EIT Health, of course, but the current program will hopefully lay basis on the future collaboration. And altogether, we have 6 webinars. The first one was on Monday. This was also recorded, and we hope to make this available for you quite soon after the program ends, so you can also take a look at what we did over this time period. A few words about the partnership that is developing this program. EIT Health is the largest health innovation network in Europe with over 200 members and a lot of funding opportunities that come with that. It covers all the stakeholder groups, private companies, doctors, academic and public sector stakeholders as well. And it provides many, many opportunities for early stage innovators, but also more established innovators and startups companies as well. Tartu Biotechnology Park is a science park, which is part of the EIT Health Risk Hub program. And we're supporting the health innovation ecosystem in Estonia, doing activities like we do, and also bringing the support from EIT Health closer to Estonian companies and innovators. And Scanbelt is a network around Baltic Sea region, which is developing Baltic Sea area as a European and global hotspot for health innovation. And jointly, we have put together a program that focuses on mental health and more specifically how to develop the mental health innovations. You can learn more on our webpage in Tartu Biotechnology Park, so that's biopark.ee, where we have the whole program, and you can take a look at that. And now today we're gonna talk a little bit more about developing and testing of technology. For that, we have with us JANEK METSALLIK, and he will open up this topic for us. You are welcome to ask questions or comment, and if you have anything to provide as a feedback, then this is also appreciated. So thank you, and JANEK, thanks for being here, and the floor is yours.
Thank you, Sven. I'm an e-health architect and currently mostly working under the roof of Tallinn University of Technology, but I have also other duties in startup world and in digital health related consultancy. And why I'm here in this field is that one of the highlights of my career has been being chief architect of the national health record system in Estonia. And since then, I have been also doing research and development in this digital health or e-health arena. And today I plan to introduce some of the ideas how to move on from this current state of affairs of e-health, and I welcome you to ask questions and comment on this topic. Related to the mental health, I'm also involved in a startup called DocuMental, where we develop decision support for mental health professionals and patients to diagnose and choose the most appropriate treatment for psychiatric diseases. But this is not the main topic for today. So probably all you have know that in Estonia we have advanced e-health infrastructure. Let's just take a quick look of this ownership or how it's governed. So this Estonian e-health system is based on Estonian e-health or e-government platform, and around this platform different stakeholders integrate their information sources and process the data that they need from others. So we have Ministry of Social Affairs, who is a bunch of units that they govern, namely, for example, Health and Welfare Informatics Center, or TEHIK, how we call it in Estonia, which is maintains the IT side of many of the systems, but there are also more business-like stakeholders like Health Board and Registry of Medicinal Products and Healthcare Pitch and Archive Foundation and National Institute of Development and so on. So this is one of the main stakeholders, but as you see, the circle is far from being complete. So not all the e-health is components of e-health under the Ministry of Social Affairs. So we have also Ministry of Interior, Ministry of Justice involved, Ministry of Economic Affairs and Communications. Then there are Public Health Insurance, which is like a separately legal unit, and some of the part of the e-health are also under the University of Tartu. And then there are private stakeholders like healthcare service providers, and interesting one is Certification Authority, which maintains big part of the important role of the e-government system. So and if we look at all of these systems that we have, then it's pretty complex environment. Like we can see, this national EHR is also displayed here, and then there are many other registries like healthcare registries and financial and so on, different governmental registries. And then also Public Health Insurance provides many registries for the e-health system. And then there are systems which are part of the more like the e-government system, like Population Registry, Business Registry, Registry of Information Systems, XRoad, Certification Authority, Digital Certificates Registry. University of Tartu is maintaining the Genome Center system, which is an important component. And then there are many others which are part of the private enterprises, healthcare service providers. And so this is the like roughly the landscape of systems. And then this means that there are hundreds of systems which like are partly governmental and partly private in this e-health system, which is one of the most advanced in the world. And the base of the e-health system is e-government platform. So XRoad is probably what you know. XRoad is an interesting invention which connects different systems of the landscape and enables this secure communication between the systems, that also addresses logically the services between the systems and enables authorization of access. So if we look at the dashboard of XRoad, this is a dynamic dashboard, but this is just a snapshot from the 1st of September this year. We can monitor the flow of information throughout the landscape. And if we look closely to this dashboard, we see that they brought out 5 most popular service providers on the XRoad. And I'm just like translating for you this technical abbreviations here. So we can see that from the top 5, 4 are related to healthcare. We see national EHR is in the top on the 1st of September. The digital prescription system is the second. A population register. Okay, you can say that this is not really eHealth, but I would say that this is a patient register actually, which many countries have to develop separately. But in Estonia, we have just integrated the population register as a patient register. And then we have also health insurance register. So you can see that these are in the most popular service providers. And if we dig into the flows of XRoad and like take first 10 days of September, top 500 flows, then we can basically see that around this national EHR, this is the whole list of healthcare service providers in Estonia. So we can see hospitals here and labs and GP centers and pharmacies and so on. So everybody is communicating with this shared health information system. And if we look closer to this, take like a 12 top flows first 10 days of September around national EHR, then we can find here basically the data flows that connect national EHR to some of the most important services of eHealth. So you can see here connection with the patient portal and this booking portal and population registry and prescription service. So all these major systems are visible in this logs of the XRoad messaging. So this is really fascinating to analyze the traffic in the most busy highway in Estonia. But does it mean that the system is perfect and ready and we don't need to do anything about it anymore? So here is the 6 boxes of different kind of decisions that one can expect that this health information that we collect and we have in the system can be made. Like a patient can make decisions about their health, clinical decisions, of course, management decisions of healthcare service providers, for example, public health and research decisions, like you want to do some clinical trial or you want to do some epidemiological research, so how you get data for that, and healthcare policy decisions and financing decisions. So how these decision makers actually collect their data. So we have really mature data sharing network. So how this data gets there. We made this survey during the Hospital Network Master Plan project 2 years ago, discussed with the stakeholders, mostly with hospitals, but also with all of these others. And what we found that they still go for data to directly to the origin of the data. So they don't really benefit from the shared infrastructure always, and they define their own path to the origin. And of course, you can imagine that if there are many connections to the clinical decisions, which means that there is lots of like duplicated data capture. So you have to collect the same data again and again because somebody just asked from you. And if we look at this national EHR, then we see that there is pretty good utilization from the perspective of clinical decisions, a little less for the patient decisions, but already much less, for example, for management or policy making or financing. And this is basically the topic that we are researching now, how to increase the interoperability, because it's natural to think that this is a cost where you go directly to the data collection again and again to the original source of the data. So let's think about this decision making a little bit. So decision making, just taking some citation or quotes from the papers. So we need to select selection from the set of alternatives using the evaluation criteria. And for example, in medicine, we need to know what are the possible diagnoses and what are the suitable treatments. So this is a decision making. So you have to apply criteria, you get the choice between alternatives. But then there are also, we can find these thoughts that in situations of high time pressure and high stakes and increased ambiguities, the experts may follow decisions that fits their experience and arrive to the course action without weighting alternatives. And this is basically what happens when you have lots of possible sources of data and lots of records to process. And basically what this is like summarizing this sentence is that here over the time with our IT capability growing, we can collect more and more data and include in the decision making, like environment data, lifestyle data, generic, some like demographic data, for example, and some clinical data. And it's natural that we expect the decisions to become better with the more data we have in available for the decision maker. But according to this expert opinion from the last slide, we see that actually in some cases, these decisions may get even worse. You can think that if you have like many screen full of information ahead of you, and you have this 10-minute appointment time as a physician, then you don't really have possibility to consume all this data. So we need decision support for the experts. Otherwise, we can't really get to the personalized medicine, what is one of our aims in Estonia. So we tried to see how this data in the national records fits with decision making. So we look at the different places of decision making. Of course, there is information capture decision making. So what kind of information you need to capture? What kind of information needs to be prepared for the algorithm? What kind of algorithms you need for decision making? What kind of options you have as a result of the algorithm, and what kind of how you execute these outcomes. And for every step, you may have a different decision support. So if you think of applying, like, for example, artificial intelligence or other kinds of decision support, then you can find decision support for information capture. You can find decision support for mapping the data to your decision algorithm. You may have an environment to run these different algorithms. You may have different options for selecting the best choice from the output, and also you may need a decision support for just executing this output, like issuing some documents or injecting some drugs or something like that. So there are many different kinds of decisions. So the decision support is not just a simple one-way street where you just need to do clinical decisions. And in Estonia, we have been looking for opportunities to apply this decision making on top of the national EHR. So again, we made a study. We took, with the help of clinical experts, we chose 9 most valuable algorithms, mostly in the cardiovascular type of disease, but also in the diabetes and this kind of like major clinical issues. We mapped these algorithms to the national EHR. So in order to do that, we understood that these parameters fit into 6 categories. we found that there are 24 sections of documents that in the national EHR, which are needed to be analyzed for these kind of algorithms. And altogether, we needed criteria for 172 data fields. So this is pretty straightforward if all the standard is in place and you know the structure of information in your EHR. So let's take one of these algorithms. So algorithm is basically saying that you need to change the treatment regime of a patient when something happens. So there are certain patients with heart failure, and they're gaining weight. So we assume that their body is retaining fluids, and so we have to change the treatment prescription. And we took the data set from national EHR and also from one of the main hospitals in Estonia, and tried to see how well this algorithm would have helped us in the past. So we took 5-year data from both of the databases, and what we found that okay, there are pretty big quantity of patients who had this diagnosis, but we couldn't really detect weight changes from the national EHR. Also, we could not really find any medication from the national EHR, but this is a problem of integration. So we just didn't integrate the prescription service, and this is just like a technical issue but the main problem is that we can't really decide about patient weight change based on the data from the national EHR. And the reason is that the national EHR collects data through certain type of events, and these events are basically when this like the encounters are ending. So there are summary documents. There are mostly summary documents in EHR, which means that when the cases are summarized, then of course the dynamics of the weight change is not really part of the summary. It's maybe just weight at the end of the case or and something like that. And there is no solution for collecting weight more often to the national EHR. In hospital system, we found at least one case where the weight change was available for a patient, and also the medication information was available. But anyway, this particular patient did not really match to this criteria of algorithm. So basically, last 5 years, at the point of this research, these algorithms would have been useless because there were no cases where this algorithm would have been generated any alerts. And that's basically the starting point. So if we want to use smart or apply some smart algorithms on top of this data that we are collecting for the national infrastructure, then we have to find algorithms which fit with the data that we collect, or we have to change the logic how we process the data in the national infrastructure. Fortunately, these other algorithms gave some more alerts in hospital system. So as a result of this study, we just advised to combine this local data from the healthcare provider with a national EHR, so there will be a higher chance to find trigger any alerts based on this knowledge in the algorithms. Let's take a closer look to this algorithm. So basically, we have 3 parameters: body weight last 3 weeks, active diagnosis of heart failure, and active prescription of diuretics. And there are 2 sub-algorithms to trigger alerts. So in one condition, A1, you introduce diuretics regime, and in condition A2, you just increase the diuretics dosage. And now the question is where this data comes from. And And this data comes from the sequence of events where you measure the body weight, or you diagnose something about the patient, or you prescribe something to the patient. So there is some data in the records. So and these are separate algorithms, this A3, A4, A5, which calculate you the current weight change in last 3 weeks. So we have to like observe the history of the weight measurement, and the same with the diagnosis and same with the prescriptions. You have to observe the history of the weight measurement, and then you can trigger this. So we have to move even further back, with the pipeline of information flow. So where this body weight can come from. So body weight can come from patient health records. So at home, somebody measures their weight and records it. Then it may come from the medical records, like you visit the doctor, you step on the scale, and you get your weight measured. And I don't know, here is no connection, but maybe you can even go to the pharmacy and let your weight recorded. But anyhow, this stream of weight measurements must be available to the place where you need to make the decision. Otherwise, you can't really make this decision. And here, the one idea is to think from the perspective of reactive system paradigm. So reactive systems are in software world. In reactive systems, you have a thing what is called back pressure. So you try to build your system this way that the demand side of data is connected to the supply side. And when demand side says that I need more data, or I can process more data, or says that I can't process so much data, then this signal goes back to the supply side of the data flow. And so the question is, can we adopt this kind of thinking in the health e-health system? So where, for example, you have this algorithm, you know that this patient belongs to certain risk group, or the patient has certain diagnosis, which means that you have to start collecting the patient weight data. So can you now signal the data capture places like the app of the patient, or the application of the physician, or some other place, that whenever they meet the patient, then they should check if we need more additional weight data from the patient. So where is this signal in the e-health? So how would in e-health we can signal from the demand side that we need more data, we need more fields to be filled in. And this is, I think, the one of the ideas how to solve these quality issues that we face with the national infrastructure, where the data is not fitting for the use in many cases. So we need to understand what kind of data can be managed by certain stakeholders, and then what kind of data they need for decision making. So the real world processes can work, but at the same time, the data sharing must adapt dynamically to this demand supply gap, let's say. So we need to have organized some way that, okay, here we have adopted certain algorithm, I don't know, through the regulative or some kind of dynamic process of registering new decision-making algorithms. And then this algorithm must be able to send back this like signals to the origin of data, that this particular patient has to step on the scale at least once in 2 weeks, for example. So this is the back pressure. So how the back pressure is today organized? So how we decide what kind of data we collect. So let's look at this 3 different kinds of data sharing mechanisms. So we have document-based sharing, which is typically the national EHR or typical EHR. So we standardize documents, we stock them in the file, and then we access the documents from one source. Then we have registry sharing, where we structure the data a bit more, and we can reorganize the data for better secondary use. And then we have reactive sharing, which is a new concept, and just for this slide set to us to see if we could organize it even better. So let's look at this document sharing. So we have healthcare service provider. Clinician works in a healthcare service provider like hospital, physician or nurse or GP, and they are managing their health records. Patient comes to the visit, they record that, okay, we had a patient with this body weight and so on. And then there are different service providers, like other specialists, some technician in a lab, for example, or some researcher, and they have need for data. So they express their demand for the data some way. So they negotiate with the healthcare service provider. Please send us the initial diagnosis, or please send us the body weight, or please record the gender and I don't know, some family history, and please record us this and this information, so we can make better decisions. And how this works? So you develop certain forms of data capture. So you organize like some order entry system in your hospital to satisfy the specialist, or you organize some case reporting to satisfy this researcher, and you organize some prescription entry to satisfy this pharmacy needs, and so on. So you add more user interface to the end user to collect the data that was demanded by this demand side. So this is how the back pressure works with document sharing. So you basically design new document standards to be filled in. So this body weight is part of the medical records, but you also copy it to certain documents. So you have to like duplicate the data entry for this document types, because this was negotiated with the other side of the use. And this kind of information sharing has been here like many hundreds of years, and we have basically digitalized it in our eHealth system. So we negotiate the document structure, and we create data entry forms for the document structure, so everybody is happy with the result. The only problem is that during this digitalization, we have also made the physician responsible for filling in the data in the computer. So the physician just has all these different screens to fill in the forms, and often they just it doesn't fit into their head what kind of fields need to be filled in which screens, and then this data quality, of course, suffers. We can discuss it, but we can discuss it at the end of the presentation as well. So basically, the question is how the data quality is controlled with document sharing, how the healthcare process is coordinated with document sharing, how the digital decision support can be implemented with document sharing, and how new data consumers can be added, and who shall be part of the government, who should govern this data standards, for example, and where is the full patient history, who in this document sharing world, how would you see where is the patient-centric view of the data? So you can imagine like this hospital information system where you have to fill in these different forms. You send these forms to different stakeholders. So who has the full knowledge of patient history? Okay, the other mode of data sharing. So we have register sharing. So we have again the same ecosystem, like we have clinician, medical records, different other stakeholders who need data. But this time we try to be more clever. So we have more stakeholders here, but also we try to mediate the need for the secondary use of data. So we bring in a new stakeholder, which is called register. And we try to analyze the demand for the data in one central register, and create a system which is called health records, where the data is already prepared or reorganized or restructured for the need of these different data users. So in this case, the register mediates the demand to these data collectors. We expect that this solves the issue of the data suppliers to comply with too many different, too much different need of data. So we still have to enter the data, but now the data is the standard of the data is maintained by the register. So you have just one party to negotiate with what kind of data you have to structure, what kind of data you have to deliver. And this demand side, they can, of course, now just access the register and get the data back from the register. And the new thing is this registry standard. So this is the knowledge, what kind of data we are sharing. And with body weight, of course, so different stakeholders again collect body weight. This body weight data goes to the health records, and then of course this secondary use of data happens through this registry. Again, we can discuss what are the advantages and challenges. So how the data quality is controlled in case of registry type of sharing, how the healthcare process is controlled, so how you organize that, what happens when, so how you control it, how reliable a registry-based decision support would be. So now we have like a central stakeholder register, and now you can run algorithms. So is it now better than with just pure document sharing? How the new data needs are introduced, who you need to negotiate to get different data. So for example, you try to run a clinical trial, or you try to adopt a new, I don't know, digital health app, and you need data from physician, or you need data from patient, who you need to negotiate with. So how do you change how to get access to the data that you need, and who shall govern them, what should be covered. And now, where is the full history of patient? Can you run algorithms which need the full history of patient? So all these advantages, challenges. So in Estonia, what we have is we have this national EHR, which is combines both like registry and also the document-based sharing. So there is some data that is customized based on the stakeholders, like the data consumer is negotiating with the data supplier that can you please fill in these fields in your documents. And then at the same time, registry also applies the like minimal quality standards on top of these documents. So how to move on from here? Obviously, you understand that these both solutions have their own benefits. Like document-based sharing is pretty agile. You can always turn to the data supplier and say that, okay, can you please fill in this form for me, because I need this data for the patient. And this is pretty agile, so you can change the document very easy. But at the same time, you are creating huge burden on filling in all these different documents and forms and reports. With registry-based sharing, of course, you understand that, okay, this is much simpler because now we have standard. now this data entry can be standardized. At the same time, when you want to change any fields in the standard or add more, express demand for more enriched data set, then it's like impossible, more or less, because you have to like go to the central registry and bring to the table your own special needs, and then expect that the central registry will adopt your needs into the common standard, which is really slow typically, and not really feasible for many different needs. So sometimes we ask that, okay, but let's stop sharing the data altogether and just build one common clinical information system and just live with that, so we don't have to really have problems with this interoperability. But I'm not expert in medicine or in health, like biology or this kind of fields, but I have a feeling that we are still like very early stage of understanding the biology in such a way that we can really we know what kind of data we need to collect, or what kind of data we eventually need for the decision making, or artificial intelligence, or this kind of modern features. So we are not really simple machines. The personalized healthcare means that the data set is endlessly improving, growing. We need to adopt to the new scientific evidence and so on. So I think that we need even more flexibility than today in developing new digital health apps and new clinical protocols and so on. And all of these need changes in the data sharing as well. So this is we need to be more agile and more diverse in this IT as well. And so that's why this idea of reactive systems is coming into the picture. Reactive systems basically say that the system has to be responsive to the user needs. So in healthcare, we also mean that, okay, I need one more field of data, so that the whole infrastructure of eHealth should respond to this. Some way I should be able, as a data consumer, to tell to the eHealth system that I need the data in different way or different form, or I need about in this patient group with this kind of risk score, I need this additional data. So it must be responsive. It must be scalable. So it should be easy to join the network and start providing or consuming data. So it should be really scalable in this kind, and it should be resilient. So it should allow us to like in air quotes, but turn back time a little bit and reorganize the data differently and really enable to change the needs. Yeah. And then also it should be event driven, so which means that when so the truth is in the data collected originally, not in the reorganized data. So the event is the source of truth. So when you enter the data in the hospital database, then this original event is the truth of the collected data, not something that is reorganized into this some kind of data warehouse or some kind of analytical data set or so on. So events still are kept intact, or it enables the scalability, of course, and supports all these other features. So how to organize this demand for data and send back the signal? So this is the base for the reactive data sharing. reactive data sharing, of course, would affect all the way back to the end user. So here, for example, this patient John Smith is working, or a physician is working with the patient John Smith, and the system asks new facts about this patient, this body weight, for example, and then the decision algorithm is run, and then it asks additional questions, and so the communication with the system is already reactive. So the system reacts to the demand and communicates the demand to the end user. So in this case, this particular patient, we need to know additional facts, and then we suggest the course of action. So it also affects how we communicate with the information system, which means that we don't have to remember so much about the different guidelines or different algorithms or different regulations, because the system helps us to navigate through this new requirements. So this is just a simple capture of how it should look like as like the architecture. So we have patient with some records, clinician with some records, researcher with some records, financial records, and they all express their demand and capture the data what they have, and so this is like really, if you know IT, then we have this like a microservice type of thinking in IT, like last 10 years or so, which says that you have to be local with your data structure decision making, but at the same time you have to be able to communicate with other kind of microsystems, and this infrastructure, eHealth infrastructure, really has to be like some kind of exchange platform. We call it often data exchange, but today this is not really data exchange platform. Today this is more like a data storage platform. But in exchange case, we really have to exchange the demand against supply and supply against demand. So the platform must match this demands and supply. And if there is a demand, then these microsystems are able to decide whether you need to enter this body weight or whether you can run your algorithm on this patient. So all these records of body weight and diagnosis and prescriptions, they all just are made available through this continuous end-to-end demand and supply communication platform, and all these local systems can then decide how they structure the data for the decision making. And then we can again decide the same questions: how the data quality is controlled in case of reactive sharing. What is data quality in this case? You have a stream of events. So when you decide that, okay, this patient record is fine, this patient record is not fine. So how this would work? How the process is controlled. So can you now see what has happened to the patient recently? Where the patient is now? What kind of information is missing about the patient? Can you control the process when you have this event stream? How can you fetch the information for decision making? Like, yeah, where is the patient, the full knowledge of the patient? How new data needs are introduced? Who you need to negotiate to introduce new needs? How this reactive infrastructure actually works? So can you just introduce data sharing standards with a group of systems which are participating in your study, but at the same time still keep the data flow through the common infrastructure? So in this reactive sharing system, yeah, can you introduce new participants and new data needs more dynamically? and what needs to be governed, who should own what, who owns the platform, who owns the local systems, and where is the full history. So we are not first and the only ones who struggle with it. There are many different theories and models behind that. One is the levels of conceptual interoperability, where we roughly see 3 different aspects of integrating the landscape systems. So the first one, and the simplest one, I would say, is the interoperability, which means that you have to be able to bring the data to the required location. So if one system collects data, another system needs the data, then you just are able to transport it. So this is what we do very well in Estonia. So XRoads and internet and everything is in place. We can easily just push a button and the data moves from one system to another. No problem here. Then there is interoperability, which means that, okay, you move the data from one system to another, but can you now process the data in this new system? So what is the data structure, and what kind of codes or what kind of elements of this structure, what they mean, what is the semantics of the data? And again, here we have done it. So we have document standards in eHealth, we have like a discharge letter, we have outpatient summary, we have prescription, we have referral, we have a lab result. So we know what is data structure and what these fields mean. So we know how to do it. So no problem with this level of interoperability as well. Then the highest level of problems is they call it composability. But basically, this means that can you now link the processes in different organizations? Can you build the information flow between the activities of pathway? Like you have patient at home, then the patient is in emergency room, then the patient is in the hospital stay, then there is a rehabilitation, then there is some GP, then different lab. So can you make these activities connected in the different institutions, with different stakeholders, and can they make decisions so that you maintain the continuity of the flow of activities? And this is, I think, where we really struggle, because we are used to think that the process is communicated from one place to another using some material means. So you walk from one building to another building, and you hand over the document, and then this triggers the next activity. But with the information flows, we don't really know yet how to combine these processes into one. So we just wait until the patient comes back to us, then we act. But how to act proactively, how to prepare the flow so this way that we don't need to move material all the time, and this really needs a different kind of thinking, and I would say we need to even change the structure of the government in some places to make it work, because these vertically structured functional organizations, they don't take lead in governing this cross organization continuity of information flow very well. So that's really something we need to work with, and when you design any new applications or systems, then you're gonna face this problem of handing over activities to new organizations and agreeing what different events mean in the data stream. You're gonna face it a lot. So in Taltech, we are also working on this together with Ministry of Social Affairs, And we are testing the idea that we can use a standard which is called CONSYS. It's ISO 13940 standard to structure the input from field of expert. So for physicians, from researchers, from public health specialists, from health finance specialists, and to map to this CONSYS language, which helps to map it further to these technical standards. And the idea is to provide a space of knowledge where the actual field knowledge is structured, and then map it to the IT. So we don't expect any of these organizations to go directly to the IT, but instead go to this common knowledge base, express their needs, and then we map them to this continuity of care standard. And then we only see what kind of technical terminologies, events, and what kind of applications are best way to manage it. So basically, we just a quick comparison of this document sharing, registry sharing, active sharing. Document sharing is we govern it basically bilateral way. So you expect the data consumer and data supplier to meet and agree on the communication. Or maybe it can be multilateral also, like hospitals come together and agree that what is a discharge letter. Okay. Agility is fair enough, so it's you can change it easily depending on what kind of governance structure you have built on top of this document. Secondary use is mostly manual because the documents are like point-to-point data transport means. So the secondary use means that you have to open the document and just copy the data to some other form. And coordination is also manual. So basically you have to bring the document to another institution and then also trigger some activities. So the communication is outside of this, or coordination is outside of this scope of the data transport with document sharing. Registry sharing is typically like a big monopoly. So you have like a very central registry which just drives all the structure of the data, or you can have many these kind of registries, like cancer registry, tuberculosis registry, diabetes registry, prescriptions registry, and I don't know, referrals registry. It can be multiple also. But it can be also federative. So you have common standards and you have local registry standards. Agility becomes a little bit lower because the registry is additional link of communication, and it slows down the process of changing the data structure. Secondary use is static. So you design the registry for certain kind of secondary use. So it's secondary use is supported, but it's basically built into this registry standard, and coordination is central. So you have to move through the central agent this data. And reactive sharing is expectedly with high agility. Secondary use is dynamic, so you can introduce new demand easily, and coordination is distributed. So if you publish an event, many institutions can start processing this event and react to this event. Okay, so we still have this gap between IT. IT says that, yeah, we know technology very well. Just tell us what you need. We can program you whatever you want. And we have healthcare. Healthcare says that we know very well how to treat the patient. But what is problem is that we need something in the middle. So let's call it eHealth, for example. So we need to train these experts who understand this, how to cross this gap between healthcare and IT. So it's still valid type of research. And you're welcome to join us in University of Technology on this digital health research area. Okay, that's all from me. Any questions?
Thank you, Janek. Do you have any questions at this stage? I will perhaps start off with a bit philosophical question, maybe, but perhaps already more clear in recent years. So, how do you feel about the European health data? So, data space, I mean. So, you showed some of the examples. How the organization of who will ask for the data and who will provide the data and what kind of processes there are in the middle. So will this create a lot of confusion? Will it actually create a lot of clarity? And if it will create many opportunities for companies, for innovators, if we look from the point of view of large data sets that could become available through that, but also if we consider any types of infrastructure, organizations and reorganizations that must be done to bring this very, very big effort alive or very big initiative alive. So what are your thoughts on the European health data space?
Mm-hmm. Yes, this European health data space is a hot topic now. And but as I see it as an architect, I see still all these different layers need to be solved. So I expect this European health data space to solve the data transport. So we know who sends us data and we can trust the transport. So there is a confidentiality and availability and this kind of security features in place, and then this is really essential to get into place. Then from the interoperability level, we already have European this patient summary standard, for example, and data content model and prescription data content model. So I see that these are maybe the initial the data flows that start to work on a larger scale. But the rest of the data interoperability still needs to be designed, and now the question is how to organize it on this kind of European level to agree on some common data standards. And then if you think further, like to this really this process level, so that you can really deliver some trigger some activities in some other countries, hospital, or I don't know, some lab. So I think this still takes time. So maybe some easy things we have seen in healthcare are like some diagnostic data sharing, like image and lab results, and these kind of things maybe become easier to share first. But then this process level also requires harmonization of the guidelines and healthcare regulations, and which is probably a little bit more challenging than just agreeing on some very basic data sets like patient summary. So yeah, I think there are many issues, but I really welcome this establishing this at least the integration level first, so that the data can be securely transported.
Yes, fully agree here. Okay, so many thanks, Janek. It was a great pleasure to have you, and many thanks for opening up these more technical questions, some more technical topics for the program that we're putting together. So for the other viewers, so happy to welcome you. It was a great pleasure to have you in this webinar, and happy to welcome you also in the next one, which will be next week, as far as I know. So thank you, and have a great evening.
Thank you.